Watching the previous video where we talked about the normal conductive pathway in the heart and how that produces the image we see on the ECG, particularly focusing on lead 2, which is the lead that is most often used, or the one that is chosen to be portrayed on our telemetry, because we can't look at all 12 leads at the same point. Or if you're talking about a 5-lead, same thing. Lead 2 is the most often the one that's picked to look at continuously. Remember, because it gives us a very good viewing point or viewing angle of the electrical activity in the heart. Looking from the bottom left, so through the apex, through the center of the heart, up to the top right of the atria. And so what we really see is that atrial contraction very well in lead 2, which is so important. We then went through what is our systematic approach to reading that telemetry strip, our 5 steps. First, check your rate, check your rhythm, and that could be both looking at the rhythm of the P to P waves, so the rhythm of the atria, and the QRS to QRS, the rhythm of the ventricles, making sure those are both regular. Then looking at the P to QRS ratio, which should be 1:1. While we're looking at that, looking at our P waves, how do they look in terms of shape? Do they look what the normal shape should be in that lead? We then go to our QRS complex shape and timing, and then looking at our PR interval and its timing. And then we touched on what some abnormalities might look like and why they look that way, and what does that mean about what's going on in the heart. So now we're going to take all that and we're going to use that to walk through some of these strips and talk our way through figuring out what's going on in this heart. So we start with number 1 up here at the top. First thing we're going to do is we're going to look for rate. So again, we have our little 3-second ticks at the top that we can use, and make sure that the QRS complex is fully in those ticks in order for it to count. So we count 1, 2, 3, 4, 5, 6, 7, 8. In a 6-second times 10, you get 60 seconds, roughly a rate of 80 beats per minute. Okay, let's check our rhythm. So if we look at our P waves, and we go the start of each P wave, so on and so forth, and you'll see it is roughly the same time, about a little over 3 boxes. Now we can go and check the Q waves as well. So we know that atrial depolarization, the timing between each one is regular and consistent. So it's a regular rhythm for the atrial. Let's double check the ventricles. And we see that the ventricles are also at a regular rhythm. There is an even timing between each one. So this is said to have a regular rhythm. Then we check our P to QRS ratio, and we see that there is 1 P wave for every QRS. Each time the atria contract, that signal is getting to our ventricles through the AV node. And there is a P wave, an atrial depolarization and contraction for every QRS complex, telling us that each heartbeat, the signal is originating in the atria, and specifically here in the sinoatrial node. So this is a 1:1. Looking at our P waves, they all look the same. A kind of semicircle upward deflection, which is what we should see, right? As atrial depolarization starts in the SA node and moves down the atria to the bottom of the atria as it depolarizes from top to bottom and gets to our AV node. So there's a nice upward deflection. So let's move on to PRI interval. So if we take a look here, and we'll look over here, we can see that we want to count the small boxes from the start of the P wave to the start of the QRS complex, and specifically the R wave, that upward deflection. So we've got 1, 2, 3, 4. 1, 2, 3, 4. We can go back. 1, 2, 3, 4. 1, 2, 3, 4, and so forth and so on. So it is a normal time, right? It is 4 boxes that falls into our 3 to 5 box category. And it's consistently 4 boxes. So our PR interval is not getting longer or shorter, meaning that there is not some sort of blockage of our signal as it's going from the atria to the ventricles. So our PR interval, it seems to be 4 boxes, which would be 0.16 seconds. Now we look at our QRS complexes. Are they all narrow or normal? And we count the boxes. 1, 2, 1, 2, 1, 2, 1, 2, and so forth and so on. Each QRS complex is narrow. 2 boxes, so about 0.08 seconds. What does that tell us? That tells us that the signal that is going through the ventricles and depolarizing them is following the conductive pathways. And that is why it is able to get through the ventricles so quickly, right? That tells us that it has to be coming from above the ventricles, either in the junction area, which is the AV node and bundle of His, the atria, or the SA node. So we look at everything that we found: a rate between 60 and 100, a regular rhythm, a 1-to-1 P to QRS ratio, a PRI interval of between 3 to 5 small boxes, and it is consistently the same PR interval, and then a QRS complex that is under 0.12 seconds and consistently that way. So what do we have here? We have normal sinus rhythm. All right. Let's move down to the second one. So again, we count our rate, we find our 6 seconds, and we count 1, 2, 3, 4, 5. So roughly 50 beats per minute. Let's look at our rhythm. Let's count a half, 1.5, 2.5, 3.5, 4.5, 5.5 between the R to R interval, or QRS complex to QRS complex. 1, 2, 3, 4, 5.5. A little over 1, 2, 3, 4, 5, a little bit more, about 5.5. A half, 1.5, 2.5, 3.5, 4.5, 5.5 small, large boxes, and it stays that way. And so we have a regular ventricular rhythm, ventricular depolarization. It is the same time between each one. And then we check the P waves just to make sure that it's also regular. So start of the P wave, 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 start of the P wave. And we check. And we have half, 1.5, 2.5, 3.5, 4.5, 5, about 5.5 boxes. Half, 1, 2, 3, 4, 5, 5.5 boxes, and it stays the same. So we have overall a regular rhythm. Check our P to QRS ratio. P wave QRS, P wave QRS, P wave QRS, P wave QRS, same thing, same thing. Okay, every P wave, every atrial depolarization is followed by a QRS complex, a ventricular depolarization. What does that tell us? That tells us that our signal is arising from somewhere in the atria or SA node. It's getting through the AV node and down to the ventricles and depolarizing them. It's not originating at the junction, which is the AV node and bundle of His. It's not originating from the ventricles. Look at our P wave morphology. It's got a little hitch in it, but that's not, we don't need to pay attention to that. But it's still a semicircle and it's upward deflecting. What does that tell us? It tells us that this atrial depolarization started in the SA node. Let's look at our PR interval. So if we count 1, 2, 3, 4, 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So PR interval is 0.16 seconds. That is in the normal range, and it's consistently that way. It's not getting shorter or longer. That's good. That tells us that our signal is getting through the atria to the AV node, through it into the ventricles in the normal amount of time it should take. So now we check our QRS complexes. They are all narrow. Okay, so we know that this is a signal that is getting to the ventricles, and it originated from above the ventricles, not from inside the ventricles. So we have less than, it's about 2 boxes, so it's roughly 0.08. So we have a regular rhythm, 1 P wave for every QRS complex, a normal, consistent PR interval, and narrow QRS complexes. What's the only thing that's abnormal? Our rate, 50 beats per minute. So we are looking at sinus bradycardia. Bradycardia, a slow heart rate that is originating from the sinus node. And then we move down to number 3. Okay, what do we see? We have our ticks here. Let's find our 3-second marks. Get our 6 seconds. And start counting our rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 in a 6 second times 10, about 120 beats per minute. How's our rhythm? Well, let's start here. P wave, P wave, P wave. Seems to be about a little over 2 boxes, and it's staying consistent. That's good. Let's check our QRS complexes, our ventricular depolarizations. And look, consistent and about 2.5 boxes. So we have a regular rhythm all around in the heart. Let's check our P to QRS ratio. And we see that we have 1 P wave for every QRS complex. And we look at that P wave, and it's a nice semicircle upward deflection. So we can understand that this signal is coming from the SA node, depolarizing the atria from top to bottom, getting to the AV node, and then depolarizing the ventricles in the normal manner. So 1 to 1. PR interval, let's check. If you count, it's about 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. And it's the same thing for the rest of this rhythm. So it's still in our 3 to 5 small boxes. This one is 0.12 seconds. Now we're going to check our QRS complex timing. See 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. 2 small boxes is how long our QRS complex is, and that stays consistent. So it's a narrow or normal QRS complex. About 0.8 seconds. So what do we have here? We have a regular rhythm. We have a P wave for every QRS complex. We have an atrial contraction or depolarization for every ventricular depolarization. We have a QRS complex timing of less than 0.12 seconds, which means it's narrow, which means that signal's following the normal conductive pathway. And so it's originating from above the ventricles, the signal. And then our PR interval is in the normal range of 0.12 seconds, and it's consistently 0.12 seconds, which means there's no blockage of the signal as it gets from the atria through the AV node to the QRS complex. The only abnormality here is our high rate of 120. So what do we have here? We have sinus tachycardia, a tachycardic rhythm of above 100 beats per minute that's still originating from the sinoatrial node. And what's interesting is Look at our PR interval. It's still normal, but look how it changed from the first and second rhythms. When we got tachycardic, there is less filling time. The SA node is firing at a faster rate, and so it shortens the timing that the electricity has to get through everything else in the heart before the next fire comes, the next impulse from the SA node comes. And so what we see is that our PR interval got a little shorter, but it's still normal. So this is sinus tachycardia. All right, we'll flip over. And we'll put that one to the side, and we'll move on to number 5. All right, so let's get our little 3 tick marks, 3-second tick marks. And let's count our rate. 1, 2, 3, 4, 5, 6, 7. So roughly 70 beats per minute. Let's check our rhythm. So our P waves, we have one here. Let's see. So let's check our P waves. We have P to P interval is about half, 1, 2, 3, about a little over 3.5. Half, 1, 2, 3, a little over 3.5. Same here, but here we get a change. This P wave, this atrial contraction, to this P wave, the start of the next atrial contraction, only takes 3 large boxes. And then from this one to the next one takes 1, 2, 3, 4, 5 large boxes. So we were at about a 3.5 large box rate, and then all of a sudden we had the shortening, and then it gets longer, and then we return back to 1, 2, 3, 4, back to our normal, just over 3.5. Interesting. Let's check our QRS complexes, or specifically our R to R interval. Normally, it's about half, 1, 2, 3, so it's about 4. Another 4. Half, 1, 2, 3, 4. Same thing, and then all of a sudden it's 3. And then 1, 2, 3, 4, 5. So just like our P waves, we have this weird rhythm in the middle of our strip where we went from about 4 large boxes between every QRS complex, and then we had down to 3, then it increased to 5 before the next one, and then returned back to about 4. So this isn't a regular rhythm, right? We were consistent, it changed, and then we returned back to what it was before. So our rhythm is considered irregular, and we'll get back to that. Okay, let's look at our P to QRS ratio. 1 P wave for QRS. Good here, good here, good here, good here. It's good here, good here, good here. Okay, so we still have 1-to-1, which means that every time the atria are depolarizing, that signal gets through, gets to the AV node. The AV node is letting it down to the ventricles. Let's check our PR interval. So if we start over here, it's about 1, 2, 3, 4. 1, 2, 3, 4, almost 5. 1, 2, 3, 4, about 5. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So it's right around 4, 4.5-ish, but it's consistently the same. Even in this area where we have this change in our rhythm, the PR interval stays the same, okay? So again, this tells us, what does this tell us? This tells us that the signal that started in the atria got to the AV node and then was sent to the ventricles in the normal time it should be, right? 3 to 5 small boxes, and it was consistently doing that. There was no slowing of that signal or shortening of that signal. So our PR interval is normal, and it is about 0.16 seconds. Let's check our QRS complexes and look at our P waves. So we have It's a little short, but that's fine. It's still an upward deflecting semicircle for every single one. Now let's check our QRS complex. Last thing. How do they look? They look narrow. And if we count, it's about 2 boxes on each one. So about 0.08 seconds, and it's consistently that way. So that tells us what? That our signal is originating from above the ventricles and taking the normal conductive pathway. We know that there's a P wave before each QRS complex, so the atria are getting depolarized, and our P wave is how it normally should look. So this signal is starting in the SA node, coming through the atria, going to the AV node, taking the conductive pathway down into the ventricles and depolarizing them. So 0.08 seconds. Okay, so what do we see here? We see a rate of 70. We have a 1-to-1 in our P to QRS ratio. We have a normal PR interval that is consistently normal, and a QRS complex that is consistently narrow or normal. Where's our irregularity here? It's in our rhythm. So if we look, we see that it was normal up until here. So we see that, look at the timing between, and all of a sudden it got shorter. What happened? We have an extra heartbeat. Okay, we have an extra heartbeat that came before when we would expect the next heartbeat to come, because it should have been about right here, right? If you look, these heartbeats start about, look at the P waves, 1, 2, 3, a half, a little bit over here, about 4. So if we count from the start of this P wave, this last normal beat, we go 1, 2, 3, 4. If this was a normal beat, it should have started right here. And we can look at the QRS complexes. It also should be about 4 in between each one. If this beat right here was normal on time, what we would say is if it was on time with the rest of the beats in this rhythm that we have, our P wave would be at this second red line, our QRS would be at this second green line. So we know that we have a premature heartbeat, okay? Now we have to determine, where is it coming from? Is it coming from the atria? Is it coming from somewhere in the junction, either the AV node or bundle of His? Or is it originating in the ventricles? How do we determine that? Okay, let's look at this beat. Does it have a P wave? It does, right here. And is it followed by a QRS complex? Yes, and then the T wave. Look at our P wave. Is our P wave a normal shape? This being an upward deflection semicircle shape. It's very small in amplitude, but we do see this upward deflecting semicircle. Is our QRS complex wide or narrow? It's narrow. It's 2 small boxes. And what does that tell us? It tells us that the signal that depolarized these ventricles was coming from above the ventricles, taking the normal conductive path, not from inside the ventricles. And our P wave is a normal shape, meaning that the atria were contracted somewhere in the atria. It could be the SA node, could be in the atria, down to the AV node. So this is called a premature atrial contraction. It looks almost identical to all of the other heartbeats, but it came earlier in the rhythm than would be expected based on the normal rhythm of heartbeats before it and after it. So this is going to be called normal sinus rhythm. With a single PAC, premature atrial contraction. All right, let's move down to number 6. And we see, whoa, we got a lot of QRS complexes. Now this one, we lose the 3, we lose the little ticks that tell us where our 3 seconds is, but if you count it out, you'll see that this has 30 large boxes. Each large box is 0.2 seconds. If you times that by 30, you will get 6 seconds. So this is a 6-second strip. So let's count our QRS complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So roughly 190 beats. Okay, so this guy is extremely tachycardic. What about our rhythm? Is it normal or not? Well, let's check. So we'll start with the QRS complexes because they're really easy to see. Is the R to R interval consistent? Yes, it's about 1.5 large boxes, and it stays that way the whole time. Now, we look for P waves. They're kind of hard to see. This rhythm is so fast that our P waves are actually being kind of buried in the T wave, but still visible at the end of the T wave. Right? If the heart rate is so quick right now that the machine doesn't have enough time to draw out the P wave because it's happening so rapidly after the preceding beat. But when you look closely at this T wave right here, you actually see a little hump, a little upward deflection. You see it on each T, at the end of each T wave, there's a little upward deflection, and that is our P wave. So you can actually measure. If you look at by marking the start of that little upward deflection on the end of our T waves, you can measure and you can see, ooh, look at that. We got about 1.5 large boxes between each one. And if you write it all out, which you should, you'll see that it is consistently that way. So our rhythm here would be regular, right? Consistent spacing between P waves and QRS complexes. Now let's check our P to QRS ratio. So we look P wave for every QRS complex. And we do find one. Again, the P wave is almost kind of coming out of our T wave because there's just not enough time between each heartbeat. And so the P wave starts to be buried inside of the T wave, but we still can kind of see it. And so we see there's a P wave for each QRS complex. So we have a 1-to-1 ratio. So that tells us that this tachycardia, it is originating from above the ventricles. We do still have atrial contraction before each QRS complex. And we also see that if we look at our P wave, or what we can see of it, it is a bit of an upward deflection. And so that at least tells us that it's likely coming from somewhere in the atria. Because if it was an upside down deflection, that means the atria would be getting contracted or depolarized from the bottom up instead of like from the top down. Now let's check our PR interval. So we could still kind of measure it. And if you look, it's only about 1 box, maybe 1.5 boxes. Consistently about 1 to 1.5 boxes. So we're going to say it's about 1.5, and that's about 0.06 seconds. Okay, so our PR interval is short. But it's consistently short. That's important. Now let's check our QRS complexes. Are they narrow or wide? They're all narrow, about 2 boxes wide, so about 0.08 seconds. So what do we have here? We have a rhythm that is regular. There is consistent timing between each atrial contraction to the next and each ventricular contraction to the next, which means nothing's getting slowed down or blocked. What about a rate? We're very tachycardic. We're above 190 beats per minute. But let's check our P to QRS ratio. It is 1-to-1. So for every atrial contraction, it's followed by a ventricular. Every ventricular contraction starts with that atrial contraction and depolarization. What about our PR interval? It's short. So this signal is getting sent from the atria through the AV node to the ventricles quickly. So quickly that the time it takes is less than what it normally should. What about our QRS complex? It's narrow or normal. That's good. That tells us that our signal is not originating in the ventricles, it's originating above it. So what do we have here? We have tachycardia that is originating somewhere in the atria above the ventricles. And we have a heart rate that is above 190. So tachycardia that has P waves, but they're barely present, and it's a tachycardia that's above 150 beats per minute, is a type of SVT, or supraventricular tachycardia. Now, supraventricular tachycardia is a class of multiple types of arrhythmias, including, but not limited to, atrial flutter, atrial fibrillation, atrial tachycardia, and a few other ones. But for now, we're just looking for identifying a supraventricular tachycardia, which usually has a heart rate of above 150 beats per minute. So it's usually tachycardic and a very high tachycardia. But it's originating from a tissue in the atria, not the SA node, though. That's very important to distinguish. In SVT, the SA node is no longer the one setting the pace. There is some other pockets of tissue, or circuit of a signal called a reentry circuit that is causing this heartbeat. All right, let's move on to this one at the top, number 7. So we're back to having our little 3-second ticks. And let's determine rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. Wow, 22 beats per minute. So we got about 220. Okay, let's look at our rhythm. Our rhythm, and do this all the way out, but for time's sake, our rhythm is about a little less than 1.5 large boxes, and it stays consistently that long. So that is a regular rhythm. We can also check our P waves. Now you might be looking at this saying, where are P waves? So let's break it down. Starting here, we have our P wave right here, followed by our QRS complex, ST segment, T wave, right into the next P wave, QRS complex, ST segment, T wave, right into the next P wave, QRS complex. So there is a P wave, this upward deflection, and it's coming right basically at the same time or at the end of our T wave. So the timing, it's a very short timing, and that's a result of this really, really fast heart rate. The T wave is actually inverted here. That's not important, but it is something we note, that it is an inverted T wave. And so again, we can measure the P waves, the P to P interval. And you'll see it's about little over one large box, and it will stay consistent throughout. So that's good. We see that we have a regular rhythm. Now let's check our P to QRS ratio. So again, this little upward deflection is our P wave QRS. And if you go through the entire rhythm strip, you'll see there is a P wave for every QRS. So atrial contraction before every ventricular contraction. In other words, atrial depolarization for every ventricular depolarization. So that's good. That means our signal is originating somewhere above the ventricles in the atria, causing it to depolarize, gets to the AV node, gets through the AV node, and into the bundle branches through the ventricles, causes them to be polarized each time. Okay, PR interval. This one's very hard, kind of hard to measure, but you'll see it's about 1, 2, 1, 2, 1, 2. It's about 2 small boxes or 0.08 seconds long. So it's short, but the question is it consistently short? And so you look and count each one, and you'll find that it is consistently 0.08 seconds. Lastly, our QRS complex. Is it wide or narrow? It's narrow, and it's about 1.5, 2 boxes each time. So about 0.08 seconds. So the question is, what do we have here? We have a regular rhythm that is extremely fast, 220 beats per minute, very tachycardic. But we have a P wave for every QRS complex. We have a PR interval that is shorter than normal, but consistent. It is the same every time. There is no slowing or speeding up of the signal. It stays a little bit quick. And that is, again, a result of this very fast heartbeat and one other thing which we'll talk about. Lastly, our QRS complex timing is 0.08. That's less than 0.12. It's narrow. We know that the signal is originating from above the ventricles and taking the normal conductive pathway through the ventricles. But what do we have here? Okay, let's think about it for a second. Do we have a wide QRS complex? No. So this signal is not originating from the ventricles. It's originating from above the ventricles. It's supraventricular signal. Good. Do we have some sort of P wave? Yes, we do. Okay, that means that this is likely originating from somewhere in the atria or the AV node. But let's look at our P wave. Can we visualize the entire P wave? No, not really. It's kind of buried in this upside down T wave that we have. So that's important. So we can't visualize the whole P wave. We're only seeing kind of the tail end of it. And can we see the shape? If I draw it out here, it kind of looks like this. Let me draw that a lot bigger. It kind of looks like this. Is that the normal P wave shape? No. The P wave should look like that, not like this, not this kind of almost, it's not even really a semicircle. Again, part of it's hidden, but what's important is that, and even if you get to over here, it actually kind of almost looks like this too. It's even got this kind of like peaked and then up to the QRS. So this is a abnormally shaped P wave. And what does that tell us? That tells us that this atrial contraction is not starting. It's not starting in the SA node and going down through the normal pathway and then down to the AV node. Because if that was happening right here, we would get our normal semicircle upward deflection. What's likely happening is that there is some sort of tissue. There is some sort of tissue in the atria that's been irritated somehow. Maybe ischemia, maybe an electrolyte imbalance, and it's causing it to generate a signal on its own, an extremely fast signal. And what that does is it completely knocks the SA node out from being in control. Your SA node's firing, but it's not capturing the atria because this little tissue right here in the atria is doing all the firing. And its impulses that it's sending out are causing depolarization of the atria before the SA node can do anything. Now it's still getting to the AV node down the normal conductive pathways and depolarizing the ventricles. But because it's not coming from the SA node and it's not depolarizing the atria in the normal order of top, left to bottom, it's creating this abnormally shaped P wave. So what we have here, it's a type of SVT, specifically called atrial tachycardia. So this is atrial tachycardia. It is a tachycardia that is originating from some sort of irritated tissue, and it's very important. It is originating from one area of tissue in the atria that is firing extremely fast, and it is depolarizing the atria and then getting to the AV node and depolarizing the ventricles on its own, preventing the SA node from controlling this conductive system anymore. If we had multiple different looking P waves, it would tell us that we have multifocal atrial tachycardia. So we would have multiple areas in the atria that are firing and causing contractions and normal and heartbeats, but they're from different areas in the atria. So that would be multifocal. This is just normal atrial tachycardia. Very fast rate, short PR interval, and an abnormally shaped P wave. Okay, let's move down to number 9. All right, so 3-second ticks right here. Let's count our rate. 1, 2, 3, 4, 5, 6, 7, 8. So about 80. Let's do our rhythm. I'm going to skip doing the P waves for now. But if we look at the QRS complexes, we see about 1, 2, 3.5 large boxes, and that's consistent throughout of 3.5 large boxes. So our rhythm is actually regular here, at least our ventricular rhythm, but overall our rhythm is still regular. The QRS complexes, or R to R interval, is consistently the same. But let's look at our P to QRS ratio. And what do we see? We see 3 upward deflections between each QRS complex. Now, every time you have a QRS complex, a ventricular depolarization, it has to repolarize. So one of these is likely the T wave, but then we have 2 P waves. So we have a ratio here of 2 P waves for every 1 QRS. Depending, this might be actually a third P wave, but it's likely some sort of T wave here. So we'll say this is 2 to 1. So we have 2 P waves, 1 QRS, 2 P waves, 1 QRS, 2 atrial contractions for every 1 ventricular contraction. In other words, 2 atrial depolarizations before one of those depolarizing signals gets through the AV node and depolarizes it, causing a QRS. So we have about a 2 to 1. Let's check. We can't really check a PR interval because, I mean, technically we could take the P wave that comes with this QRS complex and we could check it. But so let's do that actually. So if we do that, we'll check. We see about 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So it's about 0.2 seconds. That still falls in our normal range. That tells us that there's no sort of like blockage of this signal in the AV node before it gets to the QRS complex. So let's check our QRS complexes. Are they narrow or wide? They're narrow. They're about 0.08 seconds. So what do we have here? We have a regular rhythm of the ventricles, an overall, so regular rhythm, a rate of 80, which is still normal. Our PR interval is 0.2, that's normal. At least our PR interval, again, for the P waves that actually have QRS complexes. And our QRS is narrow, less than 0.12 seconds. But the important thing here is that we have a 2 to 1 ratio. For every 1 QRS complex, there was 2 P waves before it, consistently through this rhythm strip. And if you look at the shape of these P waves, they kind of look like saw teeth. So consistent ratio of 2 to 1 with a shape of the P waves looking like saw teeth. This is referred to as atrial flutter. Flutter. So what's going on here? Why is there multiple P waves before 1 QRS complex? So if we look over here at the heart, We have the SA node sitting up here and the AV node down here. Something, electrolytes, some sort of disease process, has caused tissue in the atria to form a circuit. So an impulse, an action potential, is circulating in this atrial tissue over and over and over. And as it's doing that, it's causing a depolarization of the atria this way. And then down also this way to the AV node. Again, it may be over here, it may be up here, it's not important right now. The important thing is that the AV node can only get so many signals through it and down to the ventricles, right? It has a refractory period, or a period where if a stimulus comes in, another action potential, it says, I'm not taking that thing down, it blocks it. So if we actually measured the atrial rate, which would be how many P waves we have, how many times per minute the atria are contracting, we'd actually see a much higher rate than the ventricles. It's about 160, right? 2 to 1. So we have an atrial heart rate of about 160 and a QRS or ventricular rate of about 80. And that's because as this reentry circuit keeps going around, the atria can keep depolarizing, but only one of those impulses is able to get through the AV node and down to the ventricles and depolarize them. In this case of atrial flutter, that is a 2 to 1 rate. Atrial flutter is should always be a fixed ratio, 2 to 1, 3 to 1, 4 to 1. Now, the other thing you can have is you can have tachycardia in atrial flutter, where the ventricles are trying to keep up with the atria. And so the AV node goes into overdrive, and you will see atrial flutter with a tachycardic ventricular rate. Here we do not have that. We just have atrial flutter with a 2 to 1 ratio. We have a ventricular rate that is 80 and with a normal rhythm. And if we counted all these P waves, we'd see that we have an atrial rate of 160. All right, let's see. All right, let's take a look at this number 10 right here. So count our rate. 1, 2, 3, 4, 5, 6. So about 60. But again, it's likely a little higher than 60. This is not a very accurate measurement. Let's look at our rhythm. Look at our QRS complexes. Our rhythm is all over the place. It looks like crap. Right? We have 1, 2, 3, 3.5 large boxes. 1, 2, 3, 4.5 large boxes. A half. 1, 2, 3, 4. 1, 2, 3. 1, 2, 3. Then we have 1, 2, 3, 4.5 large boxes, and then we have a half, 1.5, 2.5, 3.5, 4.5, 5.5, 6, almost 8.5 large boxes. So we have an irregular rhythm. Okay. Do we have one P wave for every QRS complex? Well, let's see. We don't see any distinct P waves here. We do see activity, these small little oscillations up from the isoelectric line, but 9 of them are a coordinated depolarization of the atria, right? Like looking like this. That's what they should look like. Instead, we have this kind of little bit of activity in the atria between each QRS complex. So we can't measure this. So we're going to say NA. Okay, can we measure a PR interval? We can't measure a PR interval. We have no coordinated atrial contraction, atrial depolarization, that then is followed by a QRS complex. So we can't measure how long it takes for a signal to get through the atria, depolarize it, get to the AV node, get through it, and down to the ventricles. So not measurable, so we'll just put NA. What about QRS timing? Well, our QRS complexes are still narrow. They're each about 2 small boxes, so that's good. That tells us that the signal that is getting to the ventricles is coming from above the ventricles, either in the SA node, the atria, the junction, which is comprised of the AV node and bundle of His. And that it's taking the normal signal pathway down to the ventricles and causing them to depolarize, which is good to know. So whatever's controlling this rate, this rhythm is originating above the ventricles. So again, let's take a look here. What do we have? What have we found? We have a normal rate, but we have a very irregular rhythm. We're unable to assess if we have any what our P to QRS ratio is, because we can't even see any distinct P wave, because there doesn't seem to be a distinct atrial depolarization, a coordinated atrial depolarization. Therefore, we can't measure PR interval, but we can still measure QRS complex timing, and that is normal, which is good. Look at this line though. Is it flat? It's not perfectly flat. There is activity in the atria. It's just chaotic. So what does this look like? If you come over here, here's the SA node, here's the AV node, and what we have is, we have a lot of irritated tissue in this atria, and they are contracting. All of these little areas in the atria are sending off their own action potentials, one after the other, at the same time. And so, what does our atria look like? It looks like this. There's just so much electrical activity going on that the atria cannot actually completely depolarize together and then send that coordinated signal down through the AV node to the ventricles. Instead, they're kind of quivering like this and kind of pushing a little bit of blood here and there into the ventricles, but nothing coordinated. There are so many impulses coming from all over the atria that are not able to create a complete, strong depolarization. And so what does that cause? That causes an irregular timing between our QRS complexes, between when a signal was actually created in the atria that can get to the AV node and then down to the ventricles, right? So chaotic activity, and then an impulse gets down through to the AV node and through that to the ventricles. Okay, chaotic, nothing's getting through, nothing. Oh, now randomly an impulse is strong enough or close enough to get to the AV node, and it causes depolarization of the ventricles. Same thing, starts again, all this chaotic atrial activity, nothing's strong enough to get to the AV node, and finally one gets through, boom. So this is why it is irregular. There's no consistent timing. There's not a single place in the atria that is creating an impulse that is causing the entire atria to depolarize at once, and then for that impulse to get to the AV node and then down to the ventricles. So it's basically a case of, man, we're just going to be sitting here contracting and depolarizing poorly until finally one gets down and the ventricles get it and they can go and they can contract. And so that's why it is irregular. So this is atrial fibrillation. Hopefully now you can have the tools to look at rhythms yourself, systematically walk through them, check the rate, the rhythm of both the ventricles and the atria, check the P to QRS ratio, look at how the P wave, its shape is. Check PR interval. Okay, is our signal that's coming from the SA node or the atria, is it getting to the AV node, through the AV node and down to the QRS complex in the normal timing? And is that consistently for each beat, or is it getting longer or shorter? Do we actually have P waves that could be seen? Or is it just chaotic activity with a random impulse getting down to the ventricles at some point? What about our QRS complex? Is it narrow, meaning the signal came from above the ventricles, either in the SA node, atrial tissue, or junction, being the AV node and bundle of His, then took the normal conductive pathway down and around, and caused ventricular depolarization very, very quickly, as it should normally happen? Or do we have a very wide QRS complex, which you can actually see right here, a very wide QRS complex with no P wave, meaning that this beat started the ventricles. And so that impulse had to slowly move through the contractile cardiomyocytes in the ventricles, causing depolarization until it got through the entire ventricular tissue, rather than taking that very good conductive pathway and happening very quickly. So that gives you an idea as to whether this impulse, this heartbeat, started in the ventricles or above the ventricles. So hopefully now you can look at certain ECGs, whatever picture you get, and piece together what's going on in that picture and what does that mean for our heart's electrical activity.